Lancashire teaching hospitals. We started this project a couple of years ago because we knew there was a huge inequity in terms of the level and care provided to people with a treatable but not curable or metastatic cancer versus those with a primary cancer diagnosis. We know that disadvantaged groups are more likely to have limited time and money to access healthcare, which can lead to late diagnosis and poorer treatment outcomes. So we looked at some data from St Helens back in 2019 that showed around 29% of people newly diagnosed with cancer that year were metastatic on presentation. We also know, obviously, that people with treatable but not curable cancer face huge uncertainty around the future and face greater emotional and practical and physical challenges that impact all aspects of their life. So we really wanted to think about creating a sustainable model of support for people with treatable but not curable cancer that could apply to all tumour sites. The challenge was we had absolutely no idea how many people that we would be looking at. We only had data about people who were newly diagnosed, not those with progression or a recurrence. So with this project, we were really seeking to ensure that people with treatable but not curable cancer can have a more equitable experience within the hospital setting, but would also provide us with some real evidence and insight to support the development of our model of holistic and personalised support rooted in the local community. So I'm now going to hand over to Hayley McCaffrey, who was the project lead for this piece of work. Over to you, Hayley.
Oh, thanks, Jo. Hi everyone, I'm Hayley McCaffrey, the Macmillan Senior Project Manager. We work alongside Diane Dearden, who's our Macmillan Lead Cancer Nurse, and Ernie Marshall, who's our Clinical Lead. But joining me on the call today is my colleague Laura Swift, who is a Macmillan Cancer Specialist Nurse. So just have a little wave there, Laura. And also Becky Hesketh, who is our Macmillan Data Analyst. So we've all been working together on the Treatable but Not Curable project. So I'll give you a TBNC project overview, and a lot of it Jo has already alluded to. Having established the problem and developed data sets, we were able to hone the investigation elements of the project. So our aim was that we were to define a core set of key principles, developing a new model of care and support for patients living with metastatic cancer. The impact being that we would develop a set of recommendations to be submitted to the Trust, Cheshire and Merseyside Cancer Alliance, Clatterbridge Cancer Centre and Macmillan for them to consider as best practice and support the implementation and delivery of a best practice model by October 2024. At the start, as Jo had said previously, our challenge was that there was no definition of the TBNC patient cohort. We needed the data to understand the population that we wanted to support. There was a lack of insight into local patient experience, and there were inconsistencies in pathways. The opportunity, though, that we had was that we had a real commitment from the Trust and from Macmillan to improve patient experience for patients living with a treatable but not curable cancer. And we also had engagement from a variety of key stakeholders like our place teams, district nursing, other members of primary care and tertiary care. And a lot of other charities also supported the project, which we would like to thank them for. Benefits and sustainability, we were able to look at this to deliver the right care and support for patients living with metastatic cancer, and we were able to work collaboratively to develop a sustainable model across Cheshire and Merseyside. I'm going to pass you on now to Laura, who's going to discuss patient engagement.
So, hi everyone. In relation to patient engagement, we have seen this as a top priority from the beginning of our project. We use the following patient engagement framework to work with our patients. So that's inform me, engage me, empower me, partner with me, and support me. So we started off with informing patients. We promoted the project via stands at St Helens and Wiston Hospital. We utilised the local press and social media to advertise our project. Macmillan supported the project by advertising on their social media pages as well. We have attended several events and support groups to promote the project within our local community. We've developed questionnaires to engage with patients, which were co-produced with our patient group. To date, we've received 46 patient responses and 18 carers responses. It hasn't always been smooth sailing all the way. We had planned on holding a patient focus group, which we had to cancel due to poor uptake, but now new dates are being planned for the summer. We have linked in with our local hospice and held events there, which were drop-in sessions. Now, although they weren't attended relatively well, it gave us invaluable feedback. Further sessions, like I've said, have been planned with the potential of extending these events to other hospices across our patch. We've engaged or plan to engage with patients in clinical settings such as district nursing teams, the Lilac Centre, outpatients and inpatient appointments. We want our patients to feel empowered to tell us their story, to develop a new model of care around what they say that they need. We completed patient stories with a thorough analysis of findings using thematical analysis. We empower patients to be part of the project and have patient representatives as core members of our steering group. We aim to partner with patients and their families to co-produce our pathways and recommendations. We will be supporting patients with our pathways and recommendations that we have produced. So now I'm just going to hand over to Becky.
Yeah, so we've met and captured feedback from a multitude of stakeholders. So that's including Mersey and West Lancs NHS teaching hospitals, hospices, including Willowbrook, St Rocco's, Halton Haven, and Marie Curie. We've been in touch with acute trusts, including Glassbridge Cancer Centre, Liverpool University's teaching hospitals, the Christie's, University Teaching Hospitals of Leicester NHS Trust, Portsmouth Hospitals NHS Trust, and Leeds Cancer Centre. And other organisations including Mersey Care, Cheshire and Merseyside Cancer Alliance, Social Prescribing, Macmillan Southport, Healthwatch, GPs, district nurses, community navigators, and NHS England, and also working with charities in the voluntary sector, so Widnes and Runcorn Cancer Support, Breastmates, Make Seconds Count, Shine Cancer Support, Sam's Diamonds, Maggie's, the Lindale Cancer Support, and lots of other groups. And they've highlighted a need for consistent approaches to personalised care interventions, such as future care planning and holistic needs assessments. It's shown that patients living with cancer should be able to access urgent care in a setting other than the emergency department. There's an inconsistent approach to delivering patient-centred care, that there's a lack of knowledge of what is available for patients in the community in terms of supports, that timely referrals to hospice care, the staff have said that they would like to work closer with patients and earlier. They aren't there just for truly palliative patients, that they can offer a wide range of services to those patients living with cancer and their families. The pressures on primary care mean that there isn't always a consistent offering for patients living with cancer, and this varies dependent on the area that you're living in. That there's no support groups for metastatic patients, with exception of breast, and that there needs to be a system-wide approach. Back to Hayley.
Actually, to Laura.
The feedback that we've received from our patient engagement so far has been really invaluable. We've used various methods, which include questionnaires, emotional mapping, patient stories, and that includes the thematical analysis. Our patients have truly opened up to us and shared their experiences, which we'll be forever grateful for. They've told us about the emotional impact on themselves and the emotional impact that a cancer diagnosis has on their families as well. They've spoken about how they feel stranded, lonely, and isolated. They just simply don't know who to turn to when they're unwell and would often present to A&E or where the GP would refer them to. They would like an alternative place to go where they don't have to sit in a waiting room with everybody else, somewhere that they can access 7 days a week. Managing pain and the side effects of treatment, all while trying to live a normal life. They are worried about money and benefits and how to navigate that system.
So as we've said previously, it really is a complex beast that we've tried to tackle here. So looking at the current pathways and the complexities of that, if you're a patient, you're going between primary, secondary and tertiary care. That is extremely complex. But what we wanted to do was establish 4 pathway work streams that we could focus on to incorporate them into our pathways and recommendations. So we focused on the key worker and the ownership of that patient follow-up, the follow-up model within an acute setting, personalised care and holistic needs assessments and future care planning. And we also looked at clinical pathways such as paracentesis. Take us to the next slide. So we have developed an urgent and emergency pathway and an elective pathway for TBNC patients. We understand they're quite busy on there and we don't expect you to read that tiny print. There's no evidence to suggest that there is an optimal pathway for metastatic patients that has been considered previously. And we know that the number of metastatic patients will increase year on year, and our pathway will ensure that patients receive the right care in the right place at the right time. And we've also built in key performance indicators, which you can briefly see in orange on your screen, that we can monitor going forward using Power BI dashboards. But just to say, these are optimal pathways. These are if the services were developed and that everything was in place, so either a 7-day service or we had that access within urgent and emergency care available to have what matters most today conversations with our patients. So these optimal pathways have built into the recommendations. So the work from the recommendations will allow us to build the optimal pathways and have them as business as usual going forward. And the next slide. So finally, that takes us on to the recommendations that have come from our project. So we've listed them here as the TBNC team and the Macmillan lead cancer nurse will scope the development of a hospital urgent cancer response service and pathway, offering a same-day assessment of urgent cancer care needs, so that what matters most to you today conversation I've just mentioned, within 4 hours of an ED referral, and it would be dependent on the working hours of the service as to what time frame we would put in as a key performance indicator. The response service should align with our current pathways, which are our in-reach acute oncology team, the brain cancer pathway, and specialist palliative care team. We could also potentially consider using them as the team that access the TBNC patients and have that what matters most conversation, but we would really need to bolster the team that offer that support. The MWL Cancer SDEC delivery group, so same day emergency care, to incorporate key TBNC requirements and recommendations into the Trust Cancer SDEC strategy. So scoping for that would include having a single point of access for urgent TBNC inquiries and linking the other available pathways that we currently have. So we have a Clatterbridge hotline, we have an MDT hub at MWL, there's a cancer hotline that patients can use. But having a consistent message that think same day emergency care for these patients, think virtual ward. We know ED is not the right place for these patients, so let's consider alternatives. That MWL and Clatterbridge Cancer Centre teams map the TBNC journey for lung, colorectal, breast and prostate and develop agreed responsibilities that promote shared care and improved communication and standards. They'll also be able to identify any gaps in the service at the moment so that we offer a consistent approach across all the tumour groups. That MWL, the Cheshire and Merseyside Cancer Alliance, Macmillan and the Mental Health and Learning Disability Coordinating Centre scope the concept of a cancer community hub, so linking primary care, community and social care and testing that model of a community key worker role, really taking the support back to the community where these patients live. Have the TBNC optimal pathway principles for urgent and emergency and elective care. As you've seen briefly, those draft pathways, we would like to pilot those across two tumour sites. It'll probably initially be breast and lung, and we'll be doing that over the summer. That takes us on to the TBNC Holistic Needs Assessment and Future Care Planning Framework. So we have that within the Trust at the moment, but we've employed 2 nurses, a digital nurse for holistic needs assessments and a CNS for the future care planning part of the project. And they're looking at key components like the timing of when these conversations are happening, the data capture and the sharing and reporting of that information going forward. That TBNC family and carers assessments and the referral for those is incorporated into the TBNC optimal pathway. We'd also like all of our cancer support workers to attend a carers check-in education event at Queen's Court, so we'll be adding that into the recommendations. The TBNC dashboard will be launched. So we have it established for lung at the moment in its draft format, and Becky's currently expanding that to breast, prostate and colorectal. Having a plan that can go out across all of the tumour groups in the long run, but building in that assurance that they're monitored and that feedback and shared learning is overseen by our clinical governance, our governance structure within cancer services. that the MWL TBNC training package is developed and shared with key stakeholders. One of the reasons we wanted to do the webinar today is about sharing the learning with our key stakeholders and making sure that all of the findings from our research and from our project are shared far and wide. But we really want to ensure that that gets out across, and we'll be hopefully doing education sessions with staff towards the end of September, October. And that is the end of the TBNC recommendations. But before we finish, I want you all to have a look at that picture. So here a piece of information, and 3 days later, you'll remember 10% of it. If you add a picture, you remember 65%. So I want you to look at that picture. These are the ladies that are our patients living with metastatic cancer. These are the people that will help as a result of the findings from this project. So thank you so much for your time, and we're open to questions. Well, finally, before we go, actually, this is just some information here. If you do have any further questions that you don't want to mention in the group, Laura will be contactable via Teams or on the number that you can see on the screen, or you can email our TBNC project email address.
Thank you, Hayley. That was really, really helpful, and a fabulous piece of work that you've done there. Just thinking about the future of this project then, obviously the recommendations you've pulled together now, which are fabulous.